Hello and welcome to Season 2, Episode 74 of the Physician Assistant Exam Review Podcast. This week, we're going to be continuing with hematology, covering red blood cells. Last week, we started off with an overview of hematology, and I talked a little bit about the way that I like to study, the way I like to cover things. I'm going to get to that a little bit at the end, but you're going to really see it come out as we cover hematology and I start doing things a little bit more the way that I think you will retain them better instead of the way that you're used to going over them. And you'll see as we go how that's going to work. One of the major keys here is that we're going to break this down. And I went through the blueprint last time, but that's not exactly how I'm going to go through everything. I don't think that it lists the information really well, but I don't think it helps you to retain the information really well with the way they have it organized. And that's one big key. I'm not going to spend too long on this, but a big key for your retention of the information, I talk a lot about active versus passive studying, is to look at the information and see how it's organized. And if it's not organized in a way that your brain's going to hold on to, that you're going to be able to remember, then maybe reorganize it. And in fact, I think if you have the time, I think reorganizing the data is one of the best ways that you can study. I think that's actually almost a flaw of having a teacher present the information as they've already organized it the way that they think it's best. And you need to get that, of course, but there's a lot to be learned by organizing the information the way that you think it works best. So anyway, today we're going to cover red blood cells in particular. We're going to cover some definitions. We're going to just get started on the blueprint just a little bit. Because there's a lot to cover here, and I don't want to go too quickly. I want you to let some of this stuff sink in. As you know, I like to get the basics down really well and then add to them as we go. So let's do that right now, and we're going to begin with our priming questions. What are the 4 polypeptide chains that make up hemoglobin? Can you name the 4 polypeptide chains that make up hemoglobin? Define polycythemia. Define polycythemia. What does MCV stand for and what does it mean? What does MCV stand for and what does it mean? Define hemolysis. Define hemolysis. All right, we're going to jump in and start talking about red blood cells. Like I said, we talked last week about the blueprint and how there are basically three issues that are 3 structures we're going to deal with when we talk about hematology. We're going to talk about red blood cells, white blood cells, and platelets. Each of those can have basically 3 problems. I mean, it'll go out from there, but just to get us off the ground, you can have too many, you can have too few, or you can have structures that aren't right, that there's something wrong with them. Those are basically the 3 options. It's almost like when you think, and I don't know if I touched on this last time or not, when you talk about heart valves, everyone gets very confused, but there's only 4 valves and each valve can have 2 problems, right? They can either be stenotic or they can be leaky. So it makes it a little bit easier if you think about it in those terms. When we talk about hematology, that's a lot of what I mean. It's a lot of what your brain should do here is just say, listen, are we talking about red blood cells, white blood cells, or platelets? Is there a problem with too many, too few, or are they producing screwed up versions and that aren't working correctly? So those are our basic problems. Polycythemia is too many red blood cells, right? Anemia is there aren't enough functioning red blood cells. And I include functioning in that term because they may be producing a lot of red blood cells, but if they don't have if the hemoglobin's broken or there's some other issue, then that also will lead to an anemia. Some simple definitions we need to just make sure we're all clear on for red blood cells. These cells have a very specific shape, right? They're kind of that donut shape that's filled in the middle. They don't have a nucleus. They don't have a lot of the organelles that normal cells have. This increases surface area and makes them very flexible and kind of bendy, so it's better for gas exchange and for fitting into tiny places like capillaries. The main job of the red blood cell is to carry oxygen to the cells and to carry the CO2 back out from the cells to the lungs, right? We all know that. Hemoglobin is the protein structure within the red blood cell that has the affinity for oxygen and CO2, right? That's the magic molecule. Hemoglobin is made up of 4 heme iron complexes and 4 polypeptide chains, 2 alpha and 2 beta chains. That becomes important down the road when we talk about thalassemias, and we'll get on that in a little, probably next show when we talk about anemias. One of the issues when we talk about issues with red blood cells in hematology, not in general, but largely, when we talk about things like anemia, patients don't normally come in with a presenting symptom. They don't come in complaining of pain or this or that. And when they do, the problem is the symptoms are super vague and very overlapping. So you get things like complaints about headaches, complaints about fatigue, exertional dyspnea, dizziness, tachycardia, blurred vision, those sorts of things. Things that aren't specific enough to help us narrow down our differential diagnosis just as the patient walks through the door. A physical exam is going to be similar. You're not going to get a lot in a physical exam, generally nothing. You may get pallor of the nail beds, pallor of the conjunctiva, and pallor of the palmar creases. If you're looking for it, those are all possible, but in general, you're not going to see a whole lot. We're going to cover some important vocabulary terms and some important labs. Reticulocytes are immature red blood cells. Reticulocytes are immature red blood cells. The mean corpuscular volume, MCV, is the volume of an average red blood cell in a sample. Right? All red blood cells can be different shapes and, well, it's a little bit different shapes, but they can be different sizes. Mean corpuscular volume measures the size of the red blood cell. Microcytosis just means small cells, right? So the MCV is less than 80. Less than 80. Macrocytosis, the MCV is greater than 100. So these are big cells. And then your average is going to be right about between 80 and 100, right? Normal cells are going to be between 80 and 100. You can get hypochromic cells, hypochromic, which means the RBCs are pale. They have a decreased color. And then our last vocabulary term for right here is hemolysis, and that's the destruction of red blood cells, which can be another cause of anemia. And red blood cells can get destroyed within the body for a number of reasons. The liver, the spleen, and even antibodies can take some out, depending in the kidneys too, depending on what's going on inside the body. Let's talk about some important labs that you'll find during hematology. A CBC is obviously going to be important. I'm not going to go through all of that there. Hemoglobin measures the amount of hemoglobin in the blood. Males should be between 13.5 and 17.5. Females are between 12 and 15.5. Why is that important? Because it's easy to ask a question on. Super easy to ask a question on. Hematocrit is the volume percentage of red blood cells in the blood. So hematocrit is what percentage of the blood is made up by red blood cells. Males are 41 to 51%. Females are 36 to 44%, generally speaking. You can be a little bit outside of those, and it's not a big deal. These are it's more like, it's sort of the same with hemoglobin. They're sort of markers. They're indicators, right? If it gets real low, it's a problem. If it gets real high, it's a problem. But let's say we have a male come in and their hemoglobin, instead of 13.5 as the lower range, is 13.2. It's really not all that exciting, right? In the operating room, you can get a kind of a quick turnaround on a hemoglobin to check for a patient if you have significant bleeding. And once they get below 7 or 8, we start to get a little concerned. That's when we start thinking about giving them blood. Up until that point, it's a little bit questionable. Obviously, blood has its own issues, and you're going to give them fluids before that. And a lot of the times, these patients that I work with are coming in for hysterectomies for excessive bleeding during menstruation or during their cycle or even throughout their cycle. So a lot of these women come in and they're living around 8 or 9 or 7, and that's why they're coming in. So sometimes we even get a pushback on doing the surgery because the medical docs look at the hemoglobin and they're like, oh, it's too low. We really should get them up before they have surgery. And the answer is we need to get the problem solved by doing the hysterectomy, and then their hemoglobin will be able to come up a little bit. But so we'll often start with patients around 7, 8, or 9 during a procedure. And then, like I said, if they drop a point or two, then we start to get a little bit concerned. And we start thinking about keeping them overnight, start thinking about giving them blood products. But in general, it's a non-issue. We do a lot of that stuff robotically now, and the amount of blood loss is so small. Usually, I create more blood loss when I make the incision to put my trocars in than we do during the actual hysterectomy part of the case. And it's the same with the hematocrit, right? We're following it as a guideline, as a trend. We're not using it as its own indicator. We're watching the hemoglobin, we're watching the hematocrit, and this just gives us an idea of what the ability of the blood to carry oxygen is. Reticulocyte count, that we talked just a second ago in our vocabulary section. Reticulocytes are immature red blood cells. So if you see a lot of reticulocytes out in the periphery, out in the blood, then you know that you're cranking out extra red blood cells. You know that you're losing red blood cells somewhere, or that for some reason production is not being completed, and you're putting out basically baby red blood cells and you're not letting them mature and then going out to do their work. So they don't function 100%. They do some work, but they're not quite 100% of what a mature red blood cell will be. So a retic count is important, and you'll see that as we move forward through anemias, deciding on which types of anemias we have. Mean corpuscular volume, we talked about that a second ago. That's the volume of an average red blood cell in a sample. So it's about how big it is. And if you remember, what was the average number we're looking for? What was the average number we're looking for? I just said it 2 seconds ago. So it's between 80 and 100. Below 80 is microcytic. Above 100 is macrocytic. And then we can also get a peripheral blood smear, and that'll give you a cell morphology or shape. So you guys know about sickle cell anemia. That's because it has that specific shape. There's a lot of different disorders or issues that have red blood cells with funny looking shapes, and a peripheral, and even white blood cells. And a peripheral blood smear will let you actually look at those cells and get an idea for the shape of the cells, and that may give you an indication for what the disease process is. All right, so that's sort of the underlying information I wanted to get to you before we got started. I think this is really, really important stuff, and a good base to have as we move through hematology and we move through our discussion of anemias, and most importantly. So this stuff makes sense. I find pure memorization to be incredibly difficult. I don't know how you do, but for me, it's very, very hard. So I like to have all this stuff done up front and understand what these values mean and what we're talking about and how to come back to them and review them, and then have the whole thing be a system instead of independent data points, which are, for me, almost impossible to understand and remember for any length of time. All right, I didn't want to get too far down the blueprint today, but I am going to start just with polycythemia. We're going to do anemias next week, or in the next section, but we're going to start with polycythemia, and that's the only one we're going to do today. Polycythemia is an elevated hematocrit or hemoglobin. So basically, we have too many red blood cells. We have an overproduction of red blood cells for one reason or another. The causes could be myeloproliferative disease. So we're just producing extra red blood cells in the bone marrow. Chronic low oxygen can cause this. You guys have heard of people, like, for example, when you climb Mount Everest, you get up, I can't remember what the level is, but at one point as you go up, the oxygen becomes so low that they actually have you camp out. I think it's for a month, which would make sense. At least a month, you camp out halfway up to let your body acclimate to the low oxygen. And what it's doing is producing more red blood cells to help you. It also is what they talk about with blood doping, right? You're adding extra red blood cells into your bloodstream to help carry more oxygen. So it's that chronic low oxygen will have your body increase the number of red blood cells in the system. A malignancy can obviously produce more red blood cells that are necessary. That's kind of a rare one from what I understand, but it is on the list. And then overtransfusion. So like I was talking about with blood doping, or in general, if you're not even on purpose, but if you're giving somebody blood and you give them too much packed red cells, then you can get an overtransfusion and wind up with polycythemia. Your clinical presentation, most likely these are going to be asymptomatic, right? You're not going to see a lot of major symptoms here. But again, if you think it through and just take a moment to consider it, you can get weakness, headaches, lightheadedness, blurred vision. Pruritus is the one that kind of stands out a little bit, especially after like a hot shower or a hot bath. Patients get very itchy. That may be one indicator that sort of clues you into a polycythemia. You can also get bleeding, specifically GI bleeding. Labs and studies. Here we've got a hematocrit greater than 55%. And our normal range, if you remember, for males and females was 36 to 50. Treatment here. The treatment here is super obvious, so it's phlebotomy. We're going to get some of that blood out of the system, not real complicated. And then hydroxyurea is a myelosuppressive medication that can be indicated if you have a long-term issue like a myeloproliferative syndrome, not like your chronic low oxygen. Then you would solve those issues. The chronic low oxygen, by the way, can also be from things like COPD or other disease processes. All right, so that's as far as I wanted to get today with that. Let's talk about our study tip for today before we move on to our priming questions and answer those for you. Our study tip for today is to continue with the use of multiple passes through information to gauge the depth you need, right? People always ask, how far down the rabbit hole do I need to go? I can get lost. I can go forever. And the answer is you don't need to go forever. And in my mind, it's a lot of times you are better off knowing the basics really well, or actually, I think this is pretty much all the time, knowing the basics really well and then adding detail to them as you have time. So you'll see in the last episode, I went through and walk through the blueprint. And I think that's something you should always do when you start a new section is walk through the blueprint, see what's important, see what they think is going to be on the test. Now, whether this is your PANCE, your PAN-RE, or a test for while you're in PA school, they usually give you a syllabus, right? With a lot of the information that's going to be on there. So you know the basic categories. Now, I agree, you don't know the depth you need to go to. But if you take all of your time and you focus down to the pathophysiology of myeloproliferative syndrome, you're not going to get to understand the differences between the anemias. And the anemias are going to come up far more than polycythemia on your exam. If you get a question on polycythemia, it's probably going to be pretty straightforward. It's not going to be super complicated. That's my guess. But anemia, you're probably going to get 10 or 15 questions, and they're going to be slightly more complicated. So you have to gauge how deep you're going to go on each of these topics. And my way of doing that is simply to make a single pass over, looking through the blueprint, and then make a very basic pass through, looking at the causes, the clinical presentations, the labs and studies, and the treatments of each disease. And then as you have time, you come back around and you go a little bit deeper and you add a few more details and you color in, right? So you start with just a sketch and then you start getting at your markers and your colored pencils and you start filling everything in. That's how you judge the depth you need to be at. And if you take a test and you realize that you're not deep enough and you're getting a lot of things wrong because everything makes sense, but you don't quite know the answer, well, then you've got to get a little deeper, right? You got to make a little more time to get a little bit further down. But if test after test are not asking anything as deep as you're going, the specific milligrams of a medication versus just the name of the medication, that kind of thing. And you have to feel it out over time. You're not expected to know right off the bat, but that's the easiest way to handle that in the most systematic way. And you'll find that systems work really, really well. I'm actually trying to push this harder in a lot of things I do and work on systems. So your system for studying and judging depth should be making multiple passes and then gauging whether you got deep enough after your exam. And if you didn't, that's not a bad thing. That's fine, right? It's actually a good thing. You learned something. So let's say you bombed a test and you think it's largely because you didn't go deep enough. All right, great. Fantastic news. Let's go ahead and go a little deeper next time. Let's say you did really well on a test and they didn't ask half the things that you studied. Well, great. Now you know you can back off a little bit. So it's a constant balancing act of moving back and forth. But I think the way to handle that of making multiple passes is really the best way to do it. That way you get your best opportunity to see everything, but not go overboard in the time you have, right? Because if time were infinite, you could spend all day on you could spend months on polycythemia. You don't have months to spend on polycythemia. That wouldn't make any sense in the position you're in. You have to make some decisions about what you're going to work on and what you're not going to work on. So to me, this system of multiple passes allows for all of that. And it allows you to adjust moving forward. All right, great. Let's answer our priming questions. What are the 4 polypeptide chains that make up hemoglobin? What are the 4 polypeptide chains that make up hemoglobin? Oh, I have something to talk about when we're done with this, so don't disappear on me just yet. What are the 4 polypeptide chains that make up hemoglobin? 2 alpha and 2 beta polypeptide chains. Define polycythemia. Define polycythemia. Do you remember? I just talked about it 2 seconds ago. Too many red blood cells. Elevated hematocrit or hemoglobin. What does MCV stand for and what does it mean? Mean corpuscular volume, MCV. Mean corpuscular volume. And it's the volume of an average red blood cell in the sample. Remember what average was across the board? 80 to 100. Define hemolysis. Define hemolysis. Destruction of red blood cells. Hemolysis is the destruction of red blood cells. All right, great. Well, I'm recording this on Tuesday. I can't even think of what the date is today, April 13th. I'm recording this on Tuesday, April 13th. And the important thing I wanted to talk about, and hopefully you're still with me, is that on Thursday of this week, I'm going to be releasing the Dream Job Package once again, which is everything I know about how to get a job. I know what people are throughout the pandemic, throughout the issues of 2020. I had a lot of people reach out to me concerned about getting jobs. A lot of people were struggling to find a job, struggling to find a position. Even seasoned PAs right out of school. I haven't really seen it like that. Usually, PAs don't have any problem getting jobs. When I graduated, everybody in our class got the job they wanted pretty much the day they graduated in the field they wanted. To me, that was pretty amazing, but that was true. It is not like that at the moment, from what I understand, from what I hear from tons and tons of people out there. Are there people finding jobs? Absolutely. And there are tons of jobs out there, but there are also people struggling to find work. So what I did last year was I put together a package of information, including a couple of past newsletters to talk about how the system that I've developed to look for, find a job that you want, get to the interview, and then absolutely rock the interview so that they want you as the candidate for the position and you get the job offer. I've got a whole system laid out. I worked really hard on it, put together a lot of information, and I think you're absolutely going to love it. I've had several people, a bunch of people reach out to me and tell me how well it's worked for them. How there were things in there they never thought to try before. There were things in there that they never considered, that their school never considered, that really helped them to land a position. There's an interview that I'm including in the package this time around with a student who struggled right out of school, who actually had bought the package, the Dream Job Package, didn't use it, struggled immensely to find something, had spent hours and hours and hours on job boards, had sent out 26 applications, hadn't heard back from anybody. And then she tried the way that I recommend, and literally the next day she had an interview. And in 10 days, she had a job offer at a place 8 minutes from her house, at the job she absolutely had dreamed about when she started school. That's why it's called the Dream Job Package, because it can and very likely could get you your dream job. And it's really, really, it's simple. It's like everything else that we do here. It's looking at it from a little bit different angle than most people do. This isn't the way that your school does it. I mean, yes, we go through resume writing in the package, and I will show you my resume and go through with you exactly how to handle that. But there's so much more to it. There's so much more to the application process than sitting behind your computer and sending in applications to Indeed, where you compete with 500 other people or 200 other people for a specific job that you may not even want. There's so much more to it. And the beauty of it is it doesn't take that long. It's not that hard. It's just a little bit different angle of coming at it. And like I said, it's worked for me for years. It's worked for a number of other people. I can't wait to get it in your hands. But that goes on sale this weekend. So and the only other way to hear about this is through the email list. So if you haven't joined the email list over at www.physicianassistantexamreview.com, head on over there and get yourself on the email list, and then you will not miss the opportunity to get the Dream Job Package. But it's only going to be available this weekend, Thursday to Sunday, with the particular package I put together, which is in my mind, spectacular. I mean, I don't know. It is just packed, filled with ways to get you where you want to go. You've worked so hard at this point to get here, to get to the finish line. I see people just sort of flounder at the end at this point, and it's really disappointing that they've put in 2-3 years and a ton of money and a ton of time, and then struggle for a couple of months to find work, and then aren't real happy with what they find. That's what I'm trying to avoid here. So head on over to www.physicianassistantexamreview.com, and you will easily be able to get onto the email list. And once you do, you will hear all about it over the weekend. So I can't wait for you to do that, and I can't wait to help you with that process. All right, folks, take care, and I will see you again, and we will be talking about anemias in the next section.